So good morning, everyone. Thank you, Javeria, for organizing the session. I'm delighted to share some of our work on hallucinations with you today. So in my lab, we've been studying hallucinations from the point of view of predictive processing or predictive coding. Everything I'm going to talk about today was done very much in collaboration with Al Powers, who's a resident in psychiatry in my lab, where we've been focusing on trying to understand the sort of profound and distressing departures from consensual reality that characterize serious mental illnesses like schizophrenia. So we focus on delusions and hallucinations. And this is our definition of what a hallucination is. It's a percept without an external stimulus, occurring in a conscious and awake state, having the qualities of real perception. So what we're going to do is take a sort of cognitive neuropsychiatric approach, focus on mechanisms of perception, and try and think about how we might apply those processes and mechanisms to think about instances where perception goes awry. This is a typical example. So a university student referred to university health services because he's hearing voices in his head a few times a week, typically male voices discussing him and commenting on his thoughts and his actions, and it's troubling, and he builds a sort of delusion-like belief around trying to explain these experiences. So in this case, he thinks that MI5, which is the security agency that James Bond is part of, is trying to kill him. We can scan people's brains whilst they're having these experiences. These are some data from the late Ralph Hoffman showing that when we ask patients to push a button whenever they're hearing a voice in the scanner, these are the sort of circuits that are active and dynamically changing as a function of voice hearing. I point these data out in particular because Ralph did something quite interesting. So here it is time zero when the individual sort of pushes the button. And what you see is that there are lots of interesting things happening cortically, both in terms of activation and deactivation, in the seconds, up to 4 seconds prior to them having the experience itself. And the circuits that seem to be engaged or modulated by the treatments that we have for these symptoms don't seem to come online until 4.5 seconds or so after someone's reported the voice hearing experience, suggesting that what we do currently when we treat these experiences is modulate the attributions rather than the interesting sort of cortical effects that are underlying the symptoms themselves. This is an example of what we think might be happening when someone has a hallucination. This is a mask of Charlie Chaplin's face rotating in a clockwise direction towards you. What you might notice, though, as you start to see the inside of the mask, is a sort of interesting perceptual effect. Right about now, it looks like the mask switched directions. It didn't actually switch directions, but your beliefs that you've accrued during your lifetime about how light falls onto faces, about how convex versus concave images tend to appear, those beliefs tend to override your perceptual data that are incident upon you, and your brain infers that actually, rather than a face pointing inwards, the mask switched direction. This is what we think is happening with hallucinations. That is, there's a bias towards your prior beliefs, so strong that you actually form perceptual inferences when there's no perceptual data there at all. And this isn't a new idea. It dates back at least to Hermann von Helmholtz, who talked about how perception isn't just merely receipt of sensory information, rather it's an active inference process of drawing conclusions about what would need to be out there in the world in order for your sensations to make sense. It's not a conscious process, but it has inference-like properties nevertheless, and it's driven by the association of ideas. So much so that perhaps we might think about all of what we perceive as, in some instances, a sort of controlled version of hallucination. And from the point of view of the data I'm going to show you today, interestingly, this inference process is driven by Pavlovian conditioning type processes. So I'm quite fond of this quote from Pavlov, who talked about these unconscious inference processes being rather like conditioned reflexes. That's what we're going to test in my lab. So you're all familiar with the process of Pavlovian conditioning. This is the process through which important sensory stimuli in the environment come to be predictors of salient events like food or punishment, so strongly that whenever the animal is confronted with the predictive stimulus, it starts to behave as though it has a very strong expectation. And I guess the argument here is the sensory models that we form of the world, the associations between sensory stimuli may be governed by the same sort of learning processes. And this isn't a new idea either. This is, for those of you who were here earlier and went to Carl Fristen's talk, the idea that predictive models are essentially what the brain is in the business of, so we need to make inferences about what would need to be, as I said, out there in the world in order for our sensory impressions to make sense. So we have a model in our brains that allows us to perform that inference. It's sort of potentially implemented through ideas about sort of Bayesian reasoning about new data in light of the models that we have, and that might be implemented sort of hierarchically, wherein predictions are passed top-down. What isn't predicted is sort of passed bottom-up as prediction errors, and the relative weighting of predictions and prediction errors may be governed by slower neuromodulatory systems like acetylcholine and dopamine. So, as I said, we're interested in conditioning effects and how they might relate to hallucinations as an example of how top-down priors can really drive our perceptions. We followed up on an effect that was first reported in the 1940s by Doug Elson, wherein he brought people into the lab, exposed them to a visual stimulus, the faint illumination of a bulb, very strongly predictive of the faint playing of a tone near to threshold, so much so over and over again that when people were confronted with the bulb illuminating, they reported hearing the tone even when none was presented. We wanted to bring all of the techniques of sort of modern psychophysics to bear on this type of an effect and to get around the criticisms around sort of demand characteristics. So the first thing that we did was have people in the scanner whilst the scanner was running, and we determined the threshold intensity of stimuli that we need to present them in order for them to be able to detect the auditory stimulus 75% of the time, 50% of the time, which is threshold, and 25% of the time, and occasionally we played no tone at all. And then we brought those tones through into a conditioning experiment wherein a very above threshold checkerboard was presented on every trial, and one of the tones of those intensities was paired with that checkerboard stimulus over and over again. And the key trials are instances where we show the checkerboard, but we don't present any tone at all. We look at what people predict in terms of whether or not they heard a tone, and we look at what happens in their brains on those trials. And again, to get around these issues of demand characteristics, we sprinkled the no-tone trials throughout the task blocks, increasingly so over time. So at the beginning of training, it's very, very clear that there's an association between the louder perceptual tones and the checkerboards, but over time we kind of break that association. We render it more and more volatile. So we can track how the beliefs form and how they're updated as time goes on in terms of trials. And we were interested in trying to pick apart what was relevant to hallucinations per se and what was driven by the side effects of having psychosis, if you like. So we identified 4 groups of subjects. People who met criteria for a diagnosed psychotic illness, so schizophrenia or schizoaffective disorder, who heard voices every day. People with a similar diagnosis who'd never heard voices and that had never been part of their sort of clinical picture. Regular controls who neither met diagnostic criteria nor had ever heard voices, and this interesting group of what we call non-clinical voice hearers, so people who don't meet criteria for a diagnosed illness, but nevertheless hear voices every day. Now don't worry, I'm not a parapsychologist, but these were all people who claimed to be clairaudient psychics. So they heard voices, and they understood those voices in a sort of metaphysical context. We were very careful to make sure that these people weren't malingering. We used tools from forensic psychiatry to make sure they weren't just making things up. And if they were doing so in a manner that most psychiatrists wouldn't be able to achieve. So we've got these 4 different groups, and we're going to look at how they perform behaviorally on our task and also in terms of their brain responses to the task. And this is what we see. So if you're somebody who hears voices in your everyday life, you're much more likely to report hearing tones that we didn't present you with in the context of our conditioning task. So when we break it down in terms of voice hearing versus not voice hearing, you're about 5 times more likely to report tones that weren't presented compared to people who don't hear voices. That's particularly the case at those low stimulus intensities, so when you're much more uncertain about whether or not a tone was presented, your prior beliefs tend to take hold and drive your inferences more strongly, particularly if you're someone who's a voice hearer. And voice hearing in everyday life correlates with your susceptibility to showing this effect. So if you're somebody who hears lots of voices, you're much more likely to report hearing tones that weren't presented to you in our task. In terms of what happens in the brain, what we were able to do was track regions of the brain during that thresholding procedure whose activity waxed and waned with stimulus intensity. And reassuringly, it's parts of the auditory hierarchy, particularly superior temporal sulcus. The nice thing we can do here is create a mask of these regions and look at what's going on in those regions during the conditioning procedure itself, particularly during those important no-tone trials. And what we find is that same region of superior temporal sulcus is hyper-engaged when people report hearing tones that we didn't actually present them with, suggesting that perhaps they're hearing something, although, of course, we wouldn't want to engage in too much reverse inference here. Interestingly, when Wilder Penfield in the 1960s did his experiments stimulating this region of cortex, when he stimulated this part, people reported hearing buzzing sounds and tones. So we think this may be an objective measure of people hallucinating in the lab. When we look outside of that very focused region of interest, we see a whole circuit, particularly regions of anterior insular cortex, the anterior cingulate, those dopamine-rich striatal and thalamic regions, a circuit, if you like, that Lisa Feldman Barrett has called the limbic sort of inference circuit. This set of regions tends to be engaged in everybody when they report a tone that isn't presented to them, report hearing something that wasn't presented. And that's really reassuring because when you look at meta-analyses of those button-pushing experiments when someone's reporting actually hearing a voice in the scanner, it's exactly the same set of regions that are engaged across all of those studies. We can engage that circuit at will with our task. There's a nice overlap between our data and the data from that particular meta-analysis, which may be useful, I think, in predicting who might be susceptible to going on to subsequently have psychosis. So perhaps a sort of imaging-based biomarker that might be predictive of people's subsequent psychotic experiences. We wanted to try and pick apart what this circuit is actually doing, though, and we turned to a computational model wherein we can make inferences about the beliefs that people have during the task, and make estimates of those beliefs and relate those beliefs to the brain responses in that circuit. This is a hierarchical model of what people might be inferring about the task. It has low-level beliefs, so we can infer what people's beliefs are about whether or not tones are occurring in the task, whether those tones are predicted by the visual stimuli, and what they can learn or infer about how those associations are changing over time. And these layers of belief are connected by learning rate parameters. Crucially, a parameter that estimates how much people weight their prior beliefs over the sensory evidence that they're currently confronted with. And that feeds out into a decision-making model, just a simple sigmoid. We think we have the right model because when we use it to simulate the data, we can recreate exactly the pattern of responses that we observed in our subjects. And so when we estimate those parameters, pleasingly, it's not the case that people are just biased if they're voice hearers. They're not just more likely to say, yes, tones were occurring. They do have stronger beliefs and tend to weight their inferences towards those beliefs more strongly if they're people who hear voices. And that manifests itself as, oh goodness. Here we go. Manifests itself as stronger beliefs that tones are occurring, that those tones are predicted by the visual stimuli. But interestingly, there's a double dissociation here. So if you're somebody who doesn't have a psychotic diagnosis, you're more able to update your beliefs in light of new evidence compared to if you're somebody who has psychosis. It's harder for you to be sensitive to the fact that associations are changing over time. And when we regress those data back onto our brain circuit, what we see is, again, that double dissociation now manifests at the level of the brain. So if you're a voice hearer, you're much more likely to engage the insula and show a strong coupling between the insular responses and that low-level belief that tones are occurring and that they're predicted by visual stimuli. And the double dissociation again here. So if you're someone with psychosis, it's much harder for you to engage the cerebellum and the hippocampus and to show an association between that ability to update your beliefs in light of new evidence. Interestingly, people have sort of challenged this predictive processing idea and sort of insisted on there being a distinction between perception and cognition. And one of their criticisms is that we're not able to intentionally control what we perceive. We can't choose to hear voices or not. Actually, when we asked the voice hearers, both clinical and non-clinical, whether or not they had volitional control over the onset and the offset of their voices, they actually report having some control. It's stronger in the non-clinical group, although some patients do report having that volitional control, and that's associated with much less distress, as you might imagine, associated with voice hearing. If you can control it, stop it from happening when you don't want it to happen, that's a much more bearable experience. When we split the groups and compare people who have control versus no control and look at what's going on in the brain during our conditioned hallucinations task, it's exactly the same set of regions that show sensitivity to that high-level belief updating parameter. So if you can switch between perceptual models and use priors with more alacrity, you're much more able to update your beliefs in light of new evidence. We think this might be a really useful approach to thinking about how we might train people to have volitional control, and maybe even use some of these regions with real-time neurofeedback to train people to be able to engage this circuitry more effectively and use it in order to update one's beliefs in light of new experiences, perhaps even with your clinical hallucinations as well as your task-based hallucinations. That's something we're actively pursuing in the lab right now. So I see I'm getting nearer to time, so I'm going to wrap up and just tell you that using computational neuroimaging, we've been able to tell the difference between people with and without hallucinations. We've been able to distinguish people who need help versus people who don't need help with those experiences. And I think we've been able to understand the underlying neural mechanisms of hallucinations, not in terms of just the regions that are engaged, but why those regions might be engaged. And the why seems to be that people who hallucinate in their everyday lives tend to bias their inferences towards their prior beliefs and what they're expecting to experience. And this is important because although we do a fairly good job of treating hallucinations and delusions with dopamine-blocking drugs, many people, about 50% of patients, don't respond to those treatments. And the ones that don't have a much worse prognosis. So I think there's a real impetus and need to understand these experiences better in order to treat them better. And I think using computational neuroimaging, we can do a much better job of that. I'll stop there and thank you for your attention. And thank the folks who actually did the work, particularly Al Powers and Chris Mathis, and the folks who funded it. Thank you.